like to thank everybody for coming tonight. If folks will take their seats, there's still some seats up front here and over on the side. We've got a really interesting program for you tonight, and some really great speakers. What I would really like to do is introduce you to Megan Antonelli. Where are you, Megan? Put your hand up. Megan arranged this entire room, right in the back there. Okay, from a lunchroom to this amazing thing before anybody got here. So thank you so much, Megan. And she also ordered all the food. She's our executive producer, one of the 4 new co-organizers at Health 2.0 New York. So if you've noticed, we've been a lot more active lately. It's not me, it's them. Okay, so they get all the credit. So they are Megan Antonelli, Donna Cusano up at the door. Donna, let's give a big hand for Donna. Thank you, Donna. Talia Moran-Straz, who's not here tonight. Talia. But she ran a great event on Wednesday. Really wonderful woman. Also a doctor. And Dr. Aafia Chaudry, who will be up in a minute. And she's right here. Yay! Okay. Big hand for Aafia. So I just want to thank all of our people, and also Sunny and Amrita and any other volunteers who came today, as well as people who come early that we also have help us do all sorts of things. So we will be taping tonight, so just so you're all informed of that. We will be putting it online, so don't say anything that you don't want online. Another thing we're doing too is it's a tweet up. So if you use ZocDoc or H2NYC with a hashtag and you're tweeting, it will show up here. So the rest of the world is watching a little bit. Mike, are we live streaming? Okay, so everybody right here, Mike Schwartz, put your hand up, Mike, the guy behind the camera. He does all of our events. As you may have seen in this cycle, he also does headshots and video sessions for great situations like, oh, look at that, MedStarter, which is my website, which is a crowdfunding site where you might need a video or a headshot or something like that. So that's enough promotional stuff. Let's get on with the Physicians 2.0 or the Providers 2.0, to be more politically correct, program. Dr. Aafia Chaudry, I met her, what was that, June of 2010. She was one of the first amazing people, along with a couple other people here tonight, who came to one of the first events that I ran personally. And she was on a panel, and she just really impressed me. And she had all kinds of great data about Twitter and social media and healthcare when nobody else had it. So she was way ahead of her time. So she's also become our Providers 2.0 leader, and she is assembling a series of amazing events, this being the first one. And without further ado, Dr. Aafia Chaudry.
Thank you, thanks Alex, and thank you for everybody who made it here through the snow. Very excited to be hosting the first Doctors, or should I say Providers 2.0 event in New York City. So Doctors 2.0, I'm going to use it interchangeably with Providers 2.0, is really a new division of the New York Healthcare Innovation Meetup Group that's really focused on providing a forum for people who are interested in the confluence of the provision of care and healthcare technology. And it's really a forum for everybody to network, collaborate, and to promote thought leadership in the area. And we would love your ideas for future events. I'm going to be making an announcement about our very special Healthcare 2020 event, which is taking place on June 26th. And that's going to be our own version of TEDMed. So there'll be an announcement about that at the end of tonight's program. So one of the questions that came up when we were having the registration process for this event was how many physicians are coming and who's in the audience. So I'd just love to get a quick show of hands in terms of who's actually here tonight. Any physicians who are practicing in the audience, if you can just wave your hands. 1, 2, 3, 4, 5, 6. Okay, Megan, there's 6 physicians here in the audience, in case you're interested. Any non-practicing MDs in the audience? Show of hands, 1, 2. Anyone else? Just 2, 3, okay. Anybody who's an allied healthcare professional? 1, just 1. Anybody who works in an academic or hospital setting? 1, 2, 3, 4, 5, 6, 7. Anybody that works in any sort of industry? Is that everybody else? Okay, great. Welcome. Thank you very much for coming here. That was actually very useful for me. And speaking of industry perspectives, Anthony Manson is going to be giving our first talk tonight. And the title of the talk is Today's Physician Managing Change. So MedPage has just instituted a new annual survey of more than 200 physicians and 200 patients to really take a finger on the pulse of what's really going on in healthcare. And some of the data that he's presenting this evening has not been shared before, so we're very excited to have some new data shared. So I'll introduce Anthony, who has more than 20 years of experience in digital media at the convergence of marketing technologies. He's been with EverydayHealth since 2010, and he leads the company's sales and marketing efforts. And he has been working in the healthcare professional marketplace since the acquisition of MedPage Today. According to his bio, the site has soared to the #1 destination for professional healthcare information. So please join me in welcoming Anthony Manson.
Thank you very much, everybody. Change, I think that's the operative word these days when it comes to healthcare. How many of you saw Escape Fire? It was on CNN the other night. Okay, some of you did. I look forward to getting your thoughts after the talk today. MedPage Today is one of the leading news sources for healthcare professionals in the country today. And we probably publish about 30+ stories every single day. We cover over 100+ conferences, and we're around the world. We're trying to really bring information to the physicians so they can put it into their practice. And as we know, everything moves in real time today. And so our reporters are moving quicker than they ever did before. We're using Twitter, we're using social media, and we're kind of on the pulse of what's going on with physicians. So as much as we wanted to really understand from both the physician and the patient perspective. Being part of Everyday Health gives us access to over 30 million patients every single month. So we wanted to kind of access information from both audiences and kind of look and compare and contrast the perceptions of what's going on out there today. Are the communications effective? Are they spending enough time together? You probably know the answer to that. But we really want to get into those insights. So I'm going to run you through kind of where the state is of this relationship and how technology, more importantly, is playing a role. I think we all hear kind of the nervousness out there today in terms of EMRs aren't working, meaningful use isn't where it needs to be, they're behind the 8 ball on it. And we all know there's a lot of promise in technology, and we know doctors are starting to rely heavily on it today. And patients, I think certainly we know they're the active health seekers, they want that information. But are they actually communicating with each other, and how does that work? So that's what this research really tries to uncover. And this is just a top line cut of the research. Certainly we'll be publishing more as we get more, and then we'll be doing an annual study comparing, see how things change over time. And I guarantee you we're going to see a lot of changes coming up. Is there a clicker? We'll just go to the next slide. Okay, next. All right, well, it looks a little frozen here. There we go. In the survey we did of 200 physicians, it became very clear in all of the data that basically we have a really frustrated audience. You know, what's gone on in the past year or 2 years alone is made them really feel like they spend more time coding and billing and dealing with the paperwork of running a practice than they do actually practicing medicine. And that's really hard for the physicians, and I think, you know, they need help, and I think that's really what came out of it was a cry for help. Don't give us this technology, don't put more restrictions on us. You know, I came into medicine to really spend time with the patient. And today, yes. Okay, can you hear me now? So I think the frustration's clearly there, but I think there's more to it than just that. So if you go to the next slide. And they've really adapted to the changes. So if you think about time management and how a physician spends their time, you know, they've had to prioritize. They've had to remove all of the lower priority tasks that they do. So, you know, they're not going to the journals anymore. They're not going to the medical conferences. 70% of all attendance at medical conferences is international today. Time spent with patients is down about 37%. Pharmaceutical reps, as we know, are no longer effective and having a harder and harder time getting in to see physicians because they just don't have the time. Patient per week load is up 43%. And that's a lot when you think about it over the last 5 years. Next slide. this really this blew my mind. Almost 10% think they're going to be out of business or have to get out of the business in the next couple of years, in the next 5 years. So I was with my own physician for a checkup about 4 months ago. He's been practicing in an upscale neighborhood in Westchester, and he's in his late 60s, and I could tell. I asked him. I said, "How are you feeling about it?" Because I know he was struggling with EMR, and he goes, "I'm counting the days to my retirement. I'm done. This is just getting way too difficult. This is not what I think medicine should be today." So difficult statistics to kind of fathom, but it's the reality of what we're dealing with today. Next. Technology is exploding. There's no question about it. 88, 90% of all doctors are using technology. EMR's penetration is certainly gaining scale. And the smartphone, the stats, 40% of our traffic comes in from a smartphone. We expect that to be 60% with physicians in the next 12 to 24 months. So it's clear that's where it's going. Next slide. Age. I get a lot of comments from people who go like, well, older doctors aren't really using technology. And that's really a myth. The data came back, it's really 50-50. So we're not seeing differences. They realize technology is here to stay. They've had to adapt. They've always been early adopters of technology. So this is not really a surprise to us. Next slide. And then certainly in terms of the way they're using the smartphone versus the desktop, all of our statistics really reinforce this, that mobile is a point of care device. They are a mobile audience. They need data at point of care, and they need those tools. Desktop is there for more education and more longer form types of content. And we really have to factor that into account when we're building applications or building different websites and brands. We need to think about who's going to be the primary audience and where's the primary point of use. This one is not a shocker to anybody that's tried to use an EMR. I was at ACC last weekend with one of the EMR companies, to remain nameless, and it was lunchtime, so the sales folks weren't there, and I asked a gentleman to demo the EMR for me. And he did a very good job, and I said, "Are you a salesperson?" He goes, "No, I'm actually a product manager." So that explained why he knew the product backwards and forwards. And I kept asking questions of, why does this screen connect to this screen? And he's like, "Well, that's the only way technically we could make it work." It's not a good answer. So I think there's a lot to we have a lot to hope for, that EMRs get better, because obviously they're going to be driving a lot of the workflow, and we really have to think through, there's 300 plus EMR companies out there today. I mean, that is incredible. So no interoperability. It is a problem. On average, we go to 5 doctors, I believe, everybody. So we're not there yet. We've got a long ways to go to really get this right for the physician. The second wave of the research, which we have not shown to anybody yet, is really the doctor-patient relationship. And this is an area that obviously EverydayHealth and MedPage Today focuses on, because we have 50 million data on 50 million patients, and we have the physician data, and we're trying to really understand what that linkage is. And it's interesting data. So 4 in 10 believe that communication is poor, according to doctors. So the doctors totally are not happy. Okay, they're not spending the time with the patient. However, the one question that's not on here that I loved is, they all thought they were doing a good job, but they thought their peers were not doing a good job in terms of communicating with patients, which I thought was interesting. Then when you go to the patient side, on the surface, it looked like the patients were satisfied. And we kept saying, how can that be? We all know what the wait times are. You get 5 minutes with a doctor. How can that be? And on the surface, it looks like they're happy. Now, maybe we've grown accustomed to that short visit. And this is across all specialties. Keep that in mind. Probably would vary in primary care versus specialists. But when you dig deeper, you see the frustration, the fear, the anxiety, the denial. So they're really afraid within that 5-minute interaction to really communicate effectively with a doctor. They're afraid to ask the questions that they should be asking. And that's why I think a lot of times we see, lack of compliance, lack of adherence, and bad outcomes. Because they're not telling the doctor, I'm not taking the pills anymore because I can't afford them. I'm not taking the pills because I just forget to take them, or I'm in denial. I don't really have a disease. And then when you compare and contrast the two together, you can see it's very consistent. So in 5 minutes, 10 minutes, you can't really get to a productive conversation about how you're going to change your lifestyle, how you're going to lose weight, how you're going to stop smoking. It is simply a transactional experience, and I think that's where you see doctors who would love to spend 30 minutes and really help somebody turn them around. Technology, I think, I've heard a lot of skepticism from a lot of people in industry and as well as doctors saying, look, technology is not the answer. It's the old way. It's human. This is about an interaction, a relationship. However, we're seeing much more receptivity in the numbers. So 80% of doctors believe that technology can actually help. So I think about all the companies out there, who can actually remote medicine, telemedicine. There's tons of companies out there, Health Tap, that I think actually can make a big difference. And I think the doctors are really getting to the point where they're saying, hey, I've got to consider this. I can't just run a factory here. We need to find other ways that we can supplement the 5 minutes, the 10-minute visit with other touch points, whether they're face-to-face or whether they're virtual. So, and 2/5 believe patients are generally more informed than 5 years ago. So I think we finally are seeing more active, empowered patients who would like to interact with healthcare professionals, maybe not between the hours of 7 a.m. and 5 p.m., but at their hours. We're used to an on-demand world when I want information, when I want it, and where I need it. And I think that's where the entrepreneurship and the startups, I think that's the hope that we have, is that those entrepreneurs can come up with solutions that really will fill in the gaps that we've identified here today. Next slide. All right, so 4 major takeaways that we found. Number 1, okay, help physicians. Give them real-time clinical information that they need to do their business. Think about the practice. We've talked to industry about, it's not just about pushing pills. Can you actually help them with their practices? Make it easier for doctors to educate patients, make it easier for them to guide them through their initial startup on managing a new diagnosis, and help the doctors. And then it's about innovative and time-saving technology. We've got to get better. The EMR companies especially can do a lot better than they're doing today. And then finally, I think, it's the patient-physician relationship. So can ExtendMD, can all of the apps that we're building that actually, like WellDoc, that link patients and doctors together and collect data, can that help in an efficient way, or is it just going to make it more difficult for doctors because they're going to be inundated with data that they can't handle? So we need to really think about the technology and how we make it user-friendly. So that's what we learned, and I'll take questions now.
Great, thanks so much, Anthony. Can you just tell us a bit about the specialties for the physicians that were in your panel?
Sure. About 50% of the 200 doctors were primary care, and the other 50% kind of cut across cardiology, endocrinology, neurology, and cardiology.
Any questions from the audience? We have a couple of minutes for questions.
Did you go into detail as to what pain points do they have in EMR, like, in general?
We dug a little bit deeper. We asked a couple additional questions. The primary pain point was just the time. It just required so much time for them to input. And, with coding ICD-9, obviously we have ICD-10 conversion coming up. I heard the ICD-10 book is like this thick, and the conversion codes are not in place yet. So for simple things, it's a headache. That's what we really heard.
So, if there's a, I'm loud enough. If there's a startup that has solutions for these 4 unmet needs, what's the best way for the startup to start engaging with a doctor? What's the best pathway forward?
I think a first step is to, from a real world, I'll call it alpha test, is to actually talk to a doctor about what their workflow is like and have them try it. Get real-time feedback. A lot of times I see us trying to develop solutions without the physicians involved, or we bring them in too late. And it's like, well, wait a second, how are you supposed to understand how a physician practices unless you actually watch them?
Hi, I'm Gina Neff at Princeton University. I would love to hear a little bit more about what the ideal, simple, and effective tool to facilitate communication with patients is. It sounds like from your survey that there was something really happening in the clinical visit itself that is a need that needs to be addressed.
I think it's, I've heard this for a long time, but I think it's unfortunately, it's just more, it's more critical now than it was before, where, people shut down, especially when you give them a diagnosis, and I'm not a physician, but in the patient's position, but you forget what they tell you. In 5 minutes, you've got 5 minutes and you've been diagnosed with a disease that you're gonna have to deal with for a long time. And most of your learning is not gonna happen in that interaction. So it's that extending that visit, as I call it. I've seen some physician portals and some other programs that says, okay, great, I know you're probably gonna think of 100 questions tomorrow. Here's a way that you can send those questions to me. I'd rather you get those questions answered by your physician as opposed to going online, and God forbid you end up on the wrong site, not EverydayHealth, of course, which is totally accurate and believable, but you end up on the wrong site and you're getting inaccurate information, or peer-to-peer social media. As much as we love it, I love it, you can't get a lot of answers by talking to other people, but their experiences are different. They're different ages, they're different genders, there's a lot of things that goes into diagnosis and treatment that is very personalized. And so you can easily go into a chat room and you can talk to somebody that's been suffering from depression for 20 years, but it doesn't mean that their situation is the same as your situation. Yet that's what's happening out there today. So as a provider, you should be going back to the provider, asking those questions and getting answers that are relevant to your situation. And unfortunately, that's not always happening.
Hi, sorry. Yeah. I was wondering if any of the physicians you talked to, I'm Rich Curry, I'm a physical therapist. I was wondering if any of the physicians you talked to had experienced any, because you talked about being inundated with information, were they using any kind of telehealth solutions, and were they experiencing any kind of like alert fatigue or information fatigue from, kind of that inundation of possibly new information that is actually out there that they might be using?
We did ask one question about email, and the doctors that were getting email, that were allowing email back and forth with patients. And, we asked the question, do you feel that is it effective? Is it helping you? Is it hurting you? Do you feel that the email is a reliable, good way to communicate a certain type of information? And I think about, it was kind of split down the middle. 1/3 felt it was, just not a great way to communicate. They weren't getting clear questions, or, they felt pressure to answer it quickly and they couldn't get to it for, just that time lag. And I think 1/3 were like totally for it, thought, oh my God, this is great. These are all the questions that, I knew they were thinking, but they wouldn't ask me, and I get to answer that. And then 1/3 were not sure yet. So I think it's still early in that dialogue, but I know it can be very helpful. I'll just take my dad as an example. My mother has Alzheimer's, and he is a leading neurologist at New York Presbyterian, and I think he's emailing her constantly. And she's been, nice enough. I've been surprised how much time she's dedicated to emailing back to him. I don't know, but I would have thought she would have been, please call my office for an appointment. And she has not done that. She's been emailing him information and advice. So I think it can be great.
Great. If anybody else has any questions, if you can reserve them for the break or the end networking session, as we'd like to just keep to time. So please join me in thanking Anthony Manson. Okay. Okay, great. We're going to move along in the program now. Our next speaker is David Lee Scher, who's an MD, and he's also the Senior Medical Advisor at Happtique. And his talk is about perspectives on medical apps. Medical apps will play a significant role in the healthcare of the future, and Happtique believes that there will be a provider and payer app formulary from which they will be prescribed and will apply its recently released standards of security, operability, privacy, and content to its app certification program. Dr. Lee is the chair of the company's Blue Ribbon Panel, which has developed standards and procedures for the certification of health, fitness, and medical apps to be used by the Happtique App Certification Program. He's also involved with the pilot of MRX, the company's patent-pending mobile app prescribing technology. He also happens to be a former cardiac electrophysiologist and possesses more than 30 years of patient care experience. Please join me in welcoming Dr. David Lee Scher.
Thank you very much. It's always good to speak in New York because I don't have to apologize for my accent. So mobile technologies really are one of 7 digital health technologies, next slide please, which fall into the ecosystem of, next slide please. Which fall into the ecosystem of what Dr. Eric Topol calls the superconvergence, which ultimately, ideally, should result in personalized medicine. And what is meant by that is that it's medicine tailored specifically for that person, so that not every person with the same diagnosis will ideally be treated the same. These technologies include wireless sensors, genomics, mobile connectivity, which is what I'm going to be speaking about, the internet and social networking, and computer power and data universe, otherwise known as big data. Next, please. So why mobile apps? Well, next slide. Over 90% of physicians believe that mobile health apps can improve their patients' outcome. They want to prescribe apps to patients. And they also believe that apps have a significant importance in connecting to the patient's electronic record. 6 out of 10 physicians state that one of the most important things they like about apps is that they can have patients scheduled for appointments and have scheduled reminders. And while that is a bread and butter issue, I think that there is much more to mobile apps than that. And that's already been achieved with ZocDoc and other companies like it. Where physicians see the importance of apps in general is in medication adherence, diabetes, and preventive medicine. Next. So what do patients really expect or look forward to with their physicians connecting with them through medical apps? 42% want to see their test results through medical apps. 33% want to have remote monitoring of their conditions through medical apps. 30% want to connect with their electronic records through medical apps, and 13% do not see any utility of medical apps. Next. So I've divided the barriers to adoption of mobile app technology into 3 not so arbitrary categories. One is the development of the mobile app itself, and the others are the physician or provider, and the third is the patient. So when it comes to designing a medical app, I have put into 5 categories what I feel are the biggest faults in producing or things that would prevent the ideal medical app from being developed. The first one is the motivation of the app development itself is misguided. And what I mean by that is that there are many people out there who have a good intention with designing an app, but they really don't know where it fits into things. So a car dealer who had a mother who passed away from something says, I got to do something about this, and I know that apps are really cool, so I'm going to connect with my cousin who's a medical student, and we're going to, make the next Facebook. The second one is the lack of clinical involvement. There are many app developers, and most of them, I would say, as a fact, do not involve clinicians or people who take care of patients in their mobile app development. And that may seem a bit surprising. It may not seem surprising to others, but the point is it's a very important point. And why is that important? Because people who take care of patients know what's involved in the non-app side of that diagnosis or that feat that the app is trying to promote. Poor attention to usability. What does that mean? It means that the patient or person who is using that app is not taken into consideration as much as they should be. And that can range from health literacy to literacy to not involving the caregiver to not knowing what that patient with that diagnosis actually goes through, and are there any ways in which the app is presented in the user interface or the user experience, which is not commensurate with a successful potential app. Not knowing the healthcare landscape, what does that mean? It means that if you give a patient an app, you can't just expect a good outcome. That there are things that go along with that. For example, there may be things that the patient has to do in addition to paying attention to that app, which have to do with either setting the app up or paying attention to other things that they should be doing, lifestyle changes, incorporating that app. And one other thing that comes to mind is really the workflow of taking care of that patient. For example, if an electronic record has analytics which algorithmically prescribe this app to the patient upon discharge, who is going to explain how to use the app to that patient? You know, so I see the burgeoning of a new, not specialty, but emphasis in healthcare with regards to this. So there will be nurses, care coordinators, and technicians that will be involved in helping the patient successfully adopt and use this app. And that's extremely important. There's now medical specialty in informatics, which will help determine, I think those physicians would help determine how to incorporate the apps in clinical practice. But as far as the nuts and bolts of actually executing it, there will be other providers necessary. Not building the app to regulatory specifications, that's a big one because there are actually hearings in Congress this week, 3 days of hearings on regulations of medical apps. And I think that I would speculate that these hearings have been spurred on by the FDA, which really has been sitting on the fence with regards to releasing its final guidance of these apps. And I'm going to talk more about that when I discuss the Happtique certification. Next. So from the physician perspective, there is a lack of awareness of apps, not in general, because most physicians do use apps, but they use them in ways that benefit them and not the patient. So they are not ignorant, but they may not be incorporating patient-facing apps in their practice. There is certainly, and very well documented, a lack of faith in safety and reliability, and we know that for a fact. When Happtique actually goes into hospitals and we start implementing a branded customized app store, the first question that we were getting initially was, how do we know these apps are safe and reliable? And that was actually the impetus for us to start our standards development and ultimately publishing those standards and starting the app certification program. There is a fear of increased work and workflow disruption. first thing a physician senses when you give them new technology is, this is something else coming at me like a tornado, and nobody has to go any further than the letters EHR before, or electronic health records, before they realize what really that means. And the point is that apps are really a patient-facing and engaging solution, which the physician will participate in, but it's not a primary physician-generated or focused technology. And I'll go into how that can be optimized in a little bit. And finally, and not minimally, is the lack of reimbursement. And that will be addressed in some degree, I believe, by Congress. The point is that fee-for-service, which is where a physician or provider gets paid for everything they do, every little or big thing they do, is on the way out, and that's a known fact. So the point is that even if there is or isn't reimbursement specifically for medical apps, I don't think that is going to make a difference in the question of whether it will or not get adopted, because I think it will. And the other thing is that there are forward-thinking organizations that are bundled payments. In other words, they get paid per diagnosis, no matter how much or no matter how efficient or inefficient they are, which really spurs them on to be efficient. And that is in the form of accountable care organizations, which you may have heard about, or other organizations which have done this way before that, much in the way of the Cleveland Clinic model or the Mayo Clinic model. Next. On the patient side, there are patients that say, I don't need an app, and those are either people that don't know what the potential of an app is, or they may not be aware of problems or diagnoses that they have that may be amenable to being addressed by an app. And that can be as simple as obesity or diabetes. Some people say they prefer person-to-person communication with a physician. I was a pioneer adopter of remote monitoring in about 13 years ago. And that is the first thing that patients sense when you introduce a technology between them and the physician, is that this is going to decrease the patient-physician quality of their relationship. And what needs to be said is that if a technology is proven and if it shows a benefit to the patient, that it will ideally actually increase not the physical interactions between the two, but virtual ones, which are actually more meaningful because, for example, with remote monitoring of implantable cardiac rhythm devices, pacemakers and defibrillators, which I worked very intensively with, it actually showed that office visits increased, not decreased. And that paradox is important because the quality of those visits is actually much higher because they're generated by problems that were discovered by the physician or the provider. So this kind of thing eliminates the usual, yearly visit, pat on the head and say everything's fine, but increases the visits that address problems that, if attended to, would prevent more significant problems from occurring in the future. Some patients voice privacy concerns. Some of them used them but didn't find them useful. And lastly, some people were not aware that they were even available. Next. So Happtique, as I said previously, because of the real perception of the lack of safety, reliability, and privacy mentioned before, formed a panel, a blue ribbon panel, that I chaired, and that was represented by renowned people in the field of patient advocacy, providers, as well as app developers. And we developed standards in the areas of safety, operability, privacy, and content. We then, after these were developed, put them out for public review for 30 days. and presented them to the FDA, the FTC, and other organizations which gave their input, and then we finalized and released the standards on February 27th. Next. Next. And next. Next. So the other thing is there are tens of thousands of apps. 42% of them have a paid business model, but only a fraction of those are making any money. And that has to do with business models and other things, reimbursement, et cetera. Next. They can be divided into health and fitness, medical information, remote monitoring, and healthcare management. Next. Now I'm going to, and we can see that apps are making headway because they're being seen in throwaway journals, which actually get more attention than the peer-reviewed journals. Next. Happtique goes next. Allows for the prescribing of medical apps by physicians. Next. Or providers. We have a list, and you can choose within a category multiple apps. Next. And then you can actually see if the patient has downloaded the app or not, and they can get reminders if they don't. These are examples of apps. This is a little wristband that gives all vital signs. Next. Real time. This is an electrocardiogram that's available on an iPhone, and I can show a demonstration of that after. This is a glucose monitor that downloads the results and sends them to the physician. Next. This is a blood pressure cuff that's connected to your iPhone. Next. Or smartphone. This is a pulse oximeter, which measures oxygen content. And so the challenges in mobile apps is really not in designing apps themselves. It's really to minimize the amount of data that's thrown at the provider. It needs to be in a filtered fashion that gives actionable data. In other words, there's no data that comes through that doesn't need to be acted upon, that it has full connectivity with EHRs. We need clinical efficacy studies. There are very few apps that have actually shown to be effective, and those studies can be done in a million different types of ways. Reimbursement I discussed. Interoperability among apps and platforms is absolutely something that needs to happen, and Qualcomm's 2Net platform is one that does that. And then we need complete, reasonable, and appropriate regulatory requirements, which I believe will come soon. Thank you very much.
Great. Thank you so much for a really interesting talk. I guess I have a question for you. You mentioned that there are very few apps out there that are making money. What have you seen in terms of best practices in terms of a monetization strategy for medical apps?
The best way is, and I think this was a failure of a recent app, which was called Zeo, and it was an app that examined patients' sleep patterns, and patients can, by changing their daytime activities, can actually affect their sleep patterns. The problem is that I think that the company failed in its mission in determining what its identity was. It sort of sat on the fence saying, well, this is really cool medically and we can help people, but didn't want to make that claim and then go through FDA review. So it sold it to consumers who really sort of got it but didn't get it, and the average person didn't see its value. So I think that an app developer has to define which sector it's going to go in, whether it's going to go into true healthcare or health or wellness and fitness on the consumer side. And there's certainly money to be made on both ends. I think there's actually more money to be made on the healthcare side because you're really replacing big old clunky technologies and making inroads with regards to improving patients' health, which is in sectors that are actually being mandated by the government. But I think that is a really big thing. The other thing is that app developers don't have to think that they're going to take their startup from the beginning all the way to becoming the next whatever. There are certainly big pharma companies and telecom companies and medical device companies that don't want to become medical app developers and will be glad to partner with quality app developers. And I think that is really a ground for fertile engagement.
Great. Okay, Dr. Scher is going to be on the panel with us later. We're going to take 2 questions and then we're going to break. So we'll take 1 question here and 1 question there. So you can start.
Thank you. Hi, my name is Charles Perry. I'm also a doctor. Quick question for you about the rate of change of the environment, given that things are moving so fast, especially app land. Clinical trials need to be longer and show efficacy, safety, et cetera. How do you make both the rate of change in technology with the long duration of trials compatible?
I don't think that you need long trials. I think that trials can be crowdsourced. They can be, it is my opinion that actually clinical research organizations, which are companies which are outsourced from pharma and device companies to perform clinical trials, will be using mobile technology in the future to real-time collect data in a much more concentrated, rapid manner. I think that the change is going to happen by 2014 when 30 million people flood the insurance market and are going to need care that is not going to be able to be provided by physicians. So I think it's going to happen very rapidly, and I think the studies may actually come from real-time implementation rather than having to come before and then be released at the time that they're needed. Yes, sir.
Thank you. I'm Peter Frischoff. I'm a digital health consultant. I'm best known as the founder of Medscape. Has the Happtique platform actually been rolled out, what you showed us in the last section there, where doctors can prescribe their apps? And one of the reasons I ask is that some of the functionality that you showed, the glucose monitor, the vital signs, if patients are prescribing them, where do patients get them? Who pays for them, all the other issues that you mentioned there. If you have actually deployed it, what have your experiences shown you?
All of the apps that I showed are available to consumers, with exception of the iPhone ECG, which needs a prescription. The Happtique platform will be available in a few weeks, actually.
Okay, great. Thank you so much. Please join me in thanking Dr. Scher, and he'll be back on the panel. Donna has an announcement for us.
Okay, actually, can everybody hear me? Now you can hear me. Hope you're enjoying this. I did have a question for Dr. Scher. How you keep track of evolving apps. For instance, Zio has been knocked out of business by fitness apps like Fitbit, because the sleep tracking that they were pricing at $400 is now at a lower price in general fitness applications. And how they in turn may be knocked out by smartphones. For instance, the new Samsung 4G now has a whole fitness app called S-Health. I'm sorry, the 4S has an app called 4S.
So that's a great question, and I think that, I mean, we in the industry get all these, rags through the internet every day, and tell us all these things, and then we get tweeted about them for the next couple of weeks. I think that on the consumer side or the patient side, it is a problem, and I think that the really good technologies that are going to make an impact will reach patients the same way that new pills are. I mean, there may be direct-to-consumer marketing of these FDA apps. There will be physicians definitely recommending them, and there will also be word of mouth. So, and the normal type of media, besides social media, will be, hopefully getting on the bandwagon as well.
Okay, great. So we're going to continue to see disruptive innovation in apps.
Absolutely.
Yeah, okay. I'd like to introduce Lois Drapin. Many of you met her at the door, who is calm as a cucumber, cool as a cucumber, and she has a special announcement.
I don't know if everyone knows this, but tomorrow there are hearings starting. The Committee on Energy and Commerce on the Communications and Technology are going to hold hearings on health information technologies, harnessing wireless innovation. And it's really about the regulation of mHealth, FDA versus ONC, and it's also about taxation of devices and apps. So Ben Chaudry will be witnessed tomorrow at the hearings. Other speakers include Ben Chaudry is the CEO of Happtique. Other speakers include George Ford of the Phoenix Center for Advanced Legal and Economic Policy Studies, Robert Jaron, Senior Director of Government Affairs for Qualcomm, Jonathan Spalter, the chairman at Mobile Future, Bradley Merrill Thompson, of course, of the mHealth Regulatory Coalition, and Dr. Dagi from a partner at HLM Venture Partners. I urge you to go to blog. I think it's blog.happtique.com. We're going to live stream it. You can sign up for reminders there tonight, and you will be able to see that. So I just want to tell everybody it might be interesting. Okay?
All right, let's hear it for Lois Drapin. Lois, the fabulous Lois Drapin. I love Lois. Lois is one of the first people in New York in healthcare that was nice to me. So, so thank you, Lois. And she sometimes is nice to me still. Not always. But you know what? It's, you know, the most important thing is to have somebody who will tell you what they really think. And that's the kind of person that Lois is. So we have a really great panel for you, but first you have, Aafia, how much time do we have? You have a 10-minute break. And so there is beer, wine, no sangria, sorry, and all sorts of great food in the back. Please talk amongst yourselves and have a great time. This is just the beginning. Thank you. That was a hint. Find your seat, okay? I'm going to introduce my good friend, Jean-Luc Neptune, MD, from Health 2.0 National, and Chelsea Rao from the New York City Economic Development Corp, which is doing some really awesome stuff. So why don't y'all come on up here, and I'll hand you guys one mic, and they have 5 minutes to talk, and you're going to tell us all about it. Everybody, let's congratulate Chelsea on the birth of her brand new
baby boy. Yeah. His name's Kieran. Thanks, that was a nice intro. I'll get you out of the light. So I'm Chelsea Rao. I'm with the New York City Economic Development Corporation, which is the city's economic development arm. We work to strengthen businesses and sectors in New York City. And you know, we've been watching the technology space in New York City for a while, and as many of you have been a part of and have seen, technology and consumer technology and B2B technology has really taken off, so that New York City is now second in the nation for venture capital funding and investment in technology businesses. And in the last couple of years, EDC played a big role in that, but in the last couple of years, we've really been watching the health tech space in particular, and looking at what are some ways that we can really take advantage of the growing tech sector in New York City and that talent that's here, as well as the city's academic medical center base and healthcare base that we have here that's just such a strong part of the city fabric. So recently, we've launched a couple of programs specifically designed to improve or help businesses grow and help the health tech sector grow overall, and hopefully make New York City the home for healthcare technology in the US. So when you think about healthcare tech companies, you really think about New York City. So I just want to say we've been partnering with some great organizations that are, you know, working out of New York City. Health 2.0, and Jean-Luc Neptune is going to talk about our programs a little bit. Startup Health, Challenge Post, who are also here tonight, and Blueprint Health are working together to really help make these programs a success. So I hope that some of these programs appeal to you as providers, as doctors, as entrepreneurs, and that you'll really participate. If you have ideas for the healthcare space, you know, please come to us at EDC. The city is actually very open to ideas. This is an interesting time for us as the administration switches over, and we'd really like to do more to make this space a great space in New York City.
All right, great. Thank you, Chelsea. And hi, everyone. Thanks for coming out tonight. My name is Jean-Luc Neptune. My friends call me JL, so please call me JL. I work with Health 2.0, the national organization. I started the New York office, and we're actually just down the block at 483 Broadway. And as Chelsea mentioned, we are the lead on 2 projects that the NYC EDC has funded. And we've been working on those projects with Startup Health. Paulina Hannon is in the room. Paulina, put your hand up. And the Challenge Post team, as well as the Blueprint Health team. And those 2 projects are, one is called NYC Pilot Health Tech, or Pilot Health Tech NYC. And that is a program that's designed to bring established stakeholder organizations, what we call hosts, and imagine that those are hospitals, provider groups, health systems, and it's intended to bring them together with innovators, small, innovative health tech companies. Many of you are working or have founded these companies, and we're really trying to narrow the gap, make it easy for the new technologies to get into the market, and make it easy for the host organizations to find new technologies to help them achieve their missions. That program is currently running. We're accepting submissions from host innovator partnerships through May 2nd. Or May 27th, right? May 27th. And we're giving away 10 grants of up to $100,000 each that can be shared between the host and the innovator organization. So a really great opportunity. If you are an innovator company, you've been knocking on doors trying to get hosts to work with you, you can walk in and say, hey, listen, we have a chance at working together and getting a $100,000 grant. So that's one program that we're working on. We had a couple of matchmaking sessions recently, and we've had a lot of excitement around that program. We're also doing another program called Innovate Health Tech and Innovate Health Tech NYC, which is for earlier stage companies, really pre-commercialization, pre-revenue companies, so smaller scale companies probably that haven't even gotten to the market yet. And this is more of an innovation competition like we run, and at Health 2.0 I run our Developer Challenge program, which is a series of innovation competitions, and this is more like those competitions that we run. And essentially the idea is show us your technology, show us what you've developed. This is for companies that are based here in New York, as is the case for the Pilot Health Tech program. And the winning company gets, or the winning teams get a prize purse of $50,000, and that's a grant that you get to keep. It's actually $50,000, 15 and 10 for first, second, and third place. And again, a great opportunity for a very early stage company to get some funding to use as your seed funding to accelerate your growth and hopefully get you to the next level. So those are two projects that we're doing with NYC EDC that we're very proud of. And I'll do a plug for one more. We're also working with the New York eHealth Collaborative on a project called the Patient Portal for New Yorkers Design Challenge. And that is essentially a challenge to build a front-end portal for the SHINY API, which is the State Health-Wide Information Network of New York. Serves about 20 million people. It's a great challenge, a price pot of $25,000, but the real opportunity is to potentially work as the vendor for the state of New York to develop this patient portal for 20 million people, which is a gigantic, tremendous opportunity. So 3 very interesting projects, all of them that are designed to drive and sustain and grow the ecosystem here in New York, and we hope to see you participate. And if you'd like to learn about any of them, go to www.health2challenge.com, www.health2challenge.com. All right, thank you.
Big hand for Chelsea and Jean-Luc. Thank you. Thank you, Jean-Luc. Thank you for helping make New York what it is. We think the #1 health tech community in the world, and we've got the data to prove it. Did you know that this group is actually twice as big as any other Health 2.0 or any other health innovation group in the world? This group right here. So you guys rock. So this all started by this guy, Eugene Barakovich, who's actually started, he got the charter from the Health 2.0 conference. And we're a volunteer organization. So thank you for all of your contributions. You guys are actually the people who listened to me when I said, please pay for the event, because we needed to rent space and buy food and things like that. So this is a member support organization. Almost all of the events that we do are your ideas. Okay, they didn't come from me. Okay, I'm just sort of the facilitator, along with our co-organizers and other great people. But for the very first event that we ever did, Dr. Arthur Lubitz was the first person to actually say yes to me when I said I need speakers who know something about social media. So I went on Twitter, and it was back when I really didn't know anything about Twitter, and he was the only doctor I saw out there who would talk to me and also had a social media presence, and so he was really an impressive guy in my book. So then after that, that was our first event we did for Health 2.0. And it was called Healthcare Social Media, Connubial Bliss or Collision Course. He was on our panel then. I haven't seen him since, but it's not true. But he was a great panelist then, very funny. He's an ENT in New York. You've got offices on ENT and allergy specialist in New York. And you have 4 offices, if I recall correctly? He's expanded. Look, I'm not up to date. So Dr. Arthur Lubitz, he's often on television, and he's very funny, and you'll find out. Another physician, a practicing physician, Dr. George Matthews, my friend right here. I met George driving down to Washington, D.C. for a Health Data Palooza, And the whole time, he asked us all a gazillion questions. Me, Matt Browning from Your Nurse Is On, and Andres Bello from, he had like a metered scale thing. It was cool. Anyway, but George was interviewing us the whole time. It was a great trip. It was one of those, Hunter S. Thompson-esque type, moments. Anyway, but now he is a practicing hospitalist at Westchester Medical Center and New York Medical College, which is one of my alma maters, as well as where he is an associate professor. He's teaching 3rd and 4th years, like I used to. And good luck with that. And of course, the fabulous Aafia Chaudry is going to be our moderator for this panel, so I'll be handing over the mic, and enjoy.
So really quickly, whilst we're handing out the mics, Dr. Scher, if you can just stand up and show everyone the back of your jacket and just tell us what that's about, that would be great.
So this is a jacket that was painted by a woman named Regina Holiday, who is an artist by trade and whose husband actually passed away in the 3 weeks from the time he was diagnosed with cancer till she was able to get his electronic records. And she has since become, because of that, probably the most well-known patient advocate in the country. She's on numerous panels in Washington and has done tireless efforts to things on behalf of patients. She's actually now working with a lot of us in getting Hallmark cards to start making cards for hospice patients. But she actually, after her husband's episode, painted a mural on a whole building in Washington, D.C. about the story, and has since painted almost 200 of these jackets, which she gets the story from the individual, usually from social media, and then you don't tell her anything about what to draw. She draws the whole thing. And she knows about you and the story.
Well, that depends on the story, David. I actually drew her for my first jacket, the entire picture.
I can't draw straight.
She completely ignored me.
For me. So this is called Return to Sender, and she knows I'm an Elvis fan because I have the same birthday as Elvis. And I was pioneering remote monitoring, and the idea behind this jacket is that physicians who monitor implantable cardiac devices know everything about what's going on with the patient's rhythm in their device, but the patients cannot get this data directly. And I have been working on a number of volunteer efforts, and they're coming to fruition. Actually, this spring I'll be presenting a pilot at the Heart Rhythm Society in Denver. So I've been working on this, and this is all about patients getting their own data from their own devices. And that's what the story of this is that the physician is actually returning the data to the patient.
Okay, so David, the other panelists are starting to leave, so we need to move along here. So Regina Holiday, look her up, 73 Cents, it's a blog, amazing woman, tells great stories. Any other members of the walking gallery here? Anyone? I've got two, so I can give one, I guess. But no, so she's got 200 and some odd of them out there. She's amazing, and you should hear all about her. And I have her card if anybody wants it. Now, back to your panel.
Thank you. Well, thank you for the panelists for joining me. The topic of tonight's panel discussion, and I'm just looking at my watch. I know that we are quite behind the schedule. So the topic is really technology in the practice setting, help or hindrance. So I have a series of questions which I'm going to ask, and I'm going to request the panel members, if you can try and keep your answers really brief, because we want to make sure that we have enough time for the audience to participate and interact with the panel. So if you can just try and be really brief in some of your answers, that would be great, and that way we can have lots of audience participation. So the first question is, how has technology replaced clinical acumen? So if you can start in the broadest sense, George, if you can just talk to the impact that you think technology has had on clinical acumen.
Obviously, thank you. Obviously, when we think about technology, because the residency I work with, a lot of the residents are much more tech savvy than a lot of us attendings. We think of it as decision support tools, where it's actually helped them reference information faster, it's helped them communicate with patients faster. There's been a lot of advantages to it. On the other hand, there is what I've sensed, there's not a good term for it, sort of maybe laziness doesn't seem to be right, where people don't feel the need to actually know something right off the bat. They can just reference it, look it up very quickly, and that takes the place of rote memorization and sometimes even understanding. Maybe we're just early on the curve, and maybe that'll change over time, but based on the 20-somethings that I work with on a daily basis, that seems to be what seems to be happening.
I would say that email, Twitter have facilitated some communication between the doctor and patient. But I think the real misunderstanding of technology is that there still needs to be a bond between the physician and the patient. And there needs to be, sometimes there can be too much democracy, and that gets in the way of patients' compliance and understanding. Because at the end of the day, a doctor's generally not going to tell you a positive thing. They're going to tell you something that's wrong with you. And sometimes people hide behind technology to not hear the diagnosis. And so it gets in the way of the real value of the patient-doctor relationship. And so I think it facilitates, when I'm monitoring a chronic patient, for example, hives, which can go on for months, email's wonderful. But when it gets in the way of defensiveness, where a patient hides behind too much information, so they can't get the key points, then it gets in the way of clinical success.
I think that technology is a positive on both ends, the provider and the patient. From the provider side, there are so many, there's such huge variance between the best and worst care in this country for a given diagnosis. And that goes, and there is a huge difference in money spent, but that's another story. But as far as quality of care, it's huge. So I see digital technology in equalizing that, that disparity. I also see technology in decreasing, I see the digital divide. If that decreases, it will decrease the divide in health literacy of patients. So I see it on both sides.
Great. All of you are probably interacting with junior doctors and medical students. Have you seen a difference in the quality of the medical graduates which are emerging in the era of Health 2.0?
Not yet, only because the competition to get into medical school is still the same. The materials and the curriculum, for that matter, is still pretty much the same. I'm sure at all the other medical schools, in New York Medical College, we are dedicating time, like a day, to talk about some of the new media, the new, we were actually going to have Dr. Lukes actually come in today. He would have talked more about how social media is being used to interact with patients. But for the most part, the requirements are the same. Again, it's just getting out there in clinical practice. People are more motivated to find some of these tools on their own, be it references or software or even translation software or apps, so they can communicate with patients. And they're the ones that are reverse mentoring a lot of us attendings as to what the right apps are to use most efficiently.
I think that, just to compare when I was in medical school to now, what would take me a week to learn can be done in a few minutes with just Google and the right reference. I think the only problem I see, and I have children who are entering university, the only problem I see is that I think that Google can sometimes narrowcast knowledge and not put the appropriate context on it. So I think sometimes the current students and my children to begin with are narrowcasting their knowledge, and they're not picking up sometimes subtle clues of watching a patient. You really learn, the biggest problem in medicine is that we were never paid to use our brains. We were paid to do procedures. I've made the best diagnoses where I've saved people's lives and gotten $80. And I've had idiot consults where I've gotten $700 to just do a mechanical device. So I think, number one, the other interesting question really is a corollary to that is, how does technology facilitate doctors communicating with other doctors? One of the biggest problems in hospitals, Mayo Clinic all the way down, is that everybody communicates, but nobody takes a stand. It's like a political debate. And so the question becomes how culturally, when doctors are trained to compete so much against each other in medical school, do they now learn to cooperate when they haven't in the past, but use their written chart as like a sanctuary in an island rather than being on the mainland?
That's excellent. From my personal viewpoint, Happtique actually has worked closely with the Association of American Medical Colleges, and they are actually going to partner with us in doing app reviews of educational apps. And their interest in this is huge. On another point, what I would like to say is that medical schools are now going towards 3 years instead of 4. And there are 10 schools that are starting it this year. It is a foregone conclusion, and this has been said by the American Medical Association, that this is going to happen all over. The way in which I see technology helping this is that hopefully that decrease in time in education will be made up by technology, and those 3 years will be better spent in these medical students learning the humanistic ways of being a good physician and not having to memorize so much stuff from the academic standpoint.
I just asked Aafia if I could make one additional comment. One of the things that we're actually doing at our residency, which I think is actually pretty unique, is we actually have a homegrown app that we're using for residents to sign out patients to each other. And it's interesting just because Journal of Medical Association just said that that was one of the top 3 or 5 major things that needs to be improved on. Communication between doctors, very similar to what you had said. The interesting thing though is what we're finding is to pilot new software, new technology, using our residents is probably one of the best ways for us to really iterate quickly and figure out what works and what doesn't, because they are much more tech savvy than we are. And things that we're finding out about user experience, screen size, order of buttons, all comes from surveys and just asking the residents to use our app. And it's been a great testing ground for us. And we think in the future it'll be useful for other apps as they come through the pipeline.
Okay, the next question has 2 components really. The first topic is, what has been the impact of technology on the physician-patient interaction? Has there been a depersonalization of this interaction, if at all? And how has technology empowering patients changed the dynamic of the interactions that you have with patients?
Again, I'm sure we all have our own little anecdotes about this. I have very good responses with patients that because they've come to it on their own, they've been able to find out more about their conditions, they've become more educated about it, and I've been able to actually become kind of the partner with them to clarify certain things or customize treatment to what they really need, because that deeper understanding does lead to better compliance and adherence and whatnot. Then on the other hand, I've got Dr. Google, where somebody will come in because they Googled something and tell me in no short terms that this is their diagnosis and I need to give them a script or admit them or whatnot. I had a guy that came in his 30s who actually was part of Doctors Online, I think which was acquired by WebMD, who got through for 40 minutes telling the emergency room doctor that he had fluctuant sepsis. He was very, he drove himself in, had no fever, had no white count, no indications of an infection, but he had looked it up on Google, and he knew he had sepsis. So when I went in there to talk to him, and looked at it, I said, "Sir, you have a lymphangitis. Basically, if you were a 5-year-old, I'd send you home, and you're not 5. So I'm going to give you a script to go home. And do you have a primary care doc?" Of course, he didn't. Maybe you should follow up with him if you get worse. But again, there's 2 sides to the sword.
To follow up on that comment, when you're sick, you're vulnerable. So you're a combination of your intellect, but you're also a combination of a 5-year-old that wants to be taken care of. The problem with Google is it doesn't really make up for the emotional component unless you had distant parents. So the real issue is, I was one of the first docs on ZocDoc, and the worst reviews I get are that I use comedy too much. But what people don't understand is, based on the way they laugh, I can tell whether they're wheezing and taking their asthma meds. So the problem is that technology is wonderful. A perfect example, I manage hives. There's no way I can keep track of somebody totally on phone calls. I would never sleep. I never do anyway, but I would never sleep. But because I'm able to use email, I'm able to really monitor these patients and increase compliance. Problem is, I have the same type patients you have. I have a guy who did research for Pfizer, and he comes in and he's going on and on about, he wants me to give the finest points of the statistics on venom desensitization and death. So happens I just spent $6,000 recertifying from my board's 4th time in 4 decades, and I actually could give him the data at least for the next 4.5 months. Just the problem is I'm 58 this month and my short-term memory's going. But the issue is that this genius, despite being an Ivy League grad, waited 9 months to come in when he almost died. So I said, where on your 800 SATs did you need to understand that, like when you lost consciousness on the street after being stung, it took you 9 months to come in? And if it did take you 9 months to come in, why do you think your questions are valid if you didn't come to the emotional maturity that you should have come in a month? So the point being, and he's of course Russian descent like my ancestors, and so of course, intellect and emotion never meet in that culture. So the issue really becomes, if the app facilitates a feeling of warmth between the physician and that, then it's good. Now, one other thing I want to mention. I'm for everybody having health care coverage, but the way this Affordable Care Act has been implemented and the way that health care, that medical records are, you're now adding 30 million people. See, I come from an insurance family and I have a business background. It just so happens my father walked out the door and was killed by a car. And so my family has both business and that. So my middle cousin is the head of Sloan Kettering, and my other cousin's on the board of LRJ, merging everybody. So the deal is that what's happening is medical, instead of my daughter having her iPhone, which facilitates downloading an app in 1.2 minutes, I'm using a medical record which is based on Microsoft technology, a Windows 95, and it's slowing me down, and I see 50 new patients a week, and this is crazy. So I have computerized records, but I'm dictating to India, and I'm letting a guy at $4 an hour put it in, while I'm paid $1,000 an hour to use my higher intellect to help care. So here's the bottom line. The bottom line is that I'm fearful that the technology is crashing the real quality and motivation of physicians like me who've been workaholics for 30 years and have worked 12-hour days. There's people in this audience who know me personally and know that you can reach me 9 a.m., 9 p.m., or 4 a.m. And when you move a doctor to a hospital-based full employment, what you're doing is decreasing their productivity by 25%. And so that's what I'm fearful of with technology.
I'm going to take the opposite side, which is the patient side. And it shouldn't be opposite because everybody should work together, but I'm going to take the patient side though. The patient side is that technology is a tool, and it's not a substitute for a physician. And that is a point that is lost on developers, it's lost on physicians, and it's lost on patients. And it must be put into perspective of a continuum of care. It is only a tool that connects the patient to the patient's disease state or what they're monitoring, or their education about what they're doing with regards to health, and also with the physician. The next point with regards to empowerment is that, and I wrote a blog piece on this, is that empowerment is not engagement. Patients need to be empowered before they're engaged. The engagement happens through the technology and the interaction between the two, but the empowerment can only be given, it must be given first. The empowerment is the sense that the patient has a responsibility and a desire to take care of their health care. That must come first and foremost before engagement even starts.
So people who know me know that I'm rather disruptive, and I'd like to disrupt my own panel. And we do actually have another chair here. So let's get a patient advocate up here. Lynn Nezen, please come up to the front.
So I really understand what was said about Dr. Google, and I understand how frustrating that is, but I will say that my own son would have died had I not gone to the internet and found the one center in the United States that had an expert in his extremely rare inborn error of metabolism. So I think that what we're hearing tonight is that there has to be some balance, and right now things are not balanced, and we are getting lost in the weeds. So we're getting all excited about this sexy technology, but it's not really working well yet. And we're focusing on aspects of the development that maybe are not as useful as they could be, and that's what I appreciated about your presentation.
First of all, just because we're doctors doesn't mean we're not patients. My sister died of a very rare cancer. My first cousin died of a rare cancer. My first cousin's father is the head of Sloan Kettering's ophthalmologic cancers, okay? I have a lot of cancer, and I buried many people before I was a doctor. My sister had a neuroepithelioma, which is a very rare disease like your son, and I found that in the days when she was sick, which was 84, I had to use books and primitive technology to get her to the NIH. So I very much value your comment, it's very valuable. But there's a big difference between the 0.1% that are dying tomorrow with rare disease and the majority of patients that have a lifelong malady that they may not be dealing with because their time is taken up by trying to earn a living in New York City or many of the other competing factors. And the question becomes the effective use of technology to compress the short doctor-patient visit so that patients are moved motivationally. So what I tend to do is give most of my advice in humor and anecdotes, and they comply better because they can remember that. And I encourage people to go home and read my Academy's website and then come back on a second visit. But again, they can't afford that second visit. The problem I'm running into is not that I'm not available to discuss for an hour. The problem I'm running into is that the affordability and the cost of just follow through is just non-existent. And that's the problem. Other factors.
Yeah, I think you hit the nail on the head when you said patients or physicians of patients also, because 80% of physicians have said that they would not do in the last weeks of life that they recommend for patients. And that is a very telling revelation to how physicians operate, not in a literal sense, but and figuratively, and how they think about medicine if it were them or their loved one. So I think that that divide needs to close, and I think that technology can do that in the sense that if physicians looked at algorithms, and they exist today, and intensivists in the ICU use them to determine which end of, quote unquote, end of life or critical interventions are useful and which ones aren't, then they would not be doing what they're doing.
Look, I'm all for patient empowerment and engagement because I think without it, care is not successful. But again, not to be contrary, but I've seen too many situations where it's been a lot of do-it-yourself medicine because somebody wants to shortcut it. They don't want to see the doctor. They don't want to spend the money. And I get that. It's not cheap to go see a care provider. But sometimes that actually compounds the problem to the point that you made where somebody waits an extra amount of time. They think they've treated it. They try an alternative treatment, which, again, I believe some alternative treatments work, but there is data that's out there. People don't always research it. They get a recommendation from somebody. They talk to their mom. They try chicken soup. They try anything because they think, I don't have the time for it. And then, quite honestly, there is an expiration point beyond which we cannot help as a physician. Again, I'm not saying this as, I am doctor, bow before me. It is more, I want to be a trusted advocate. Here's what I know. Tell me what you know. Let's work together and figure this out. There are tools out there that you can use to manage your condition, because what's right for you may not be right for the next person. But until we get to a point where we have enough aggregated data where you can actually glean some insight from that, it's still something we're working towards. And I think, I don't want this to be adversarial in any way, but we do need to recognize that sometimes trying to do it on your own isn't always the best thing.
Okay, I just want to remind the panel, if we can try and keep our questions, answers brief, that would be fantastic. Okay, thank you. So the next question, and this is going to be my last question, I'm going to cut my part short just so we can get the audience involved, is really about the future of electronic health records. What do you think the future looks like, and how much information should be shared with patients?
Actually, I'm going to start at the end over there with Lynn and then work our way back.
I had this utopian vision that somehow the emergence of electronic health records would actually destigmatize sensitive material. And in the same way that we're very comfortable now flipping our cards in and out of ATMs and letting all kinds of information live on the web that 20 or 10 years ago we never would have thought was even a reasonable thing to do, that somehow all of these conditions which we feel need to be kept in the closet can be surfaced. And in the same way that nobody in New York anymore has to be afraid of raising their hand and saying, I like men instead of women. I know we can't do that in many parts of the country. But I was hoping somehow that the emergence of this technology would foster that degree of essentially destigmatization, so we could stop spending all this time and energy worrying about keeping everything secret. Because if we're still focused on that 5 years from now, the entire enterprise is going to fail, in my opinion.
I totally agree. I think that electronic health records are different than, say, financial records in the sense that de-identified data, which means that you can't trace it to that individual, are extremely important in discovering ways to treat new diseases, in discovering outbreaks of epidemics in their clutches, and we've seen this with Twitter and other things. It's an easier way to do research, and I don't think that anybody, I don't think that people take their health history or should as sacred as their identity. And I think those two things are, probably will go by the wayside, and I think they have to be.
Two things about health records. I mean, number one, if you ever saw my handwriting, you'd need the Rosetta Stone to interpret it. Now that I'm doing electronic records, I can actually read a week later what I was thinking. So I think from a baseline communication point of view, it's wonderful. Now let's talk about the downside a little. Number one, the government is demanding certain information from us right now that doesn't reflect total quality, but it's the best data they can come up with. So the current incarnation is primitive. The other thing is that most of these records are Microsoft-driven things that are 15-year-old technology that my children would never tolerate on an iPhone or a Samsung. So I think they need to come up to the point where they don't interfere with the doctor-patient interaction. And number two, I think the records are generating a lot of extraneous information that actually get in the way of doctors being effective. A 4-page history for strep throat is not really valuable. And so I think that going forward in the 2 generations from now, when it'll be much more user-friendly and you'll be able to bring in algorithms that help you with your decision-making without having to have read 50 journals, I think that's valuable. But I think the current incarnation has been hijacked by Microsoft and GE, and I actually think it's leading to less efficient physicians. I spent a year of a nightmare the last year, not worrying about my boards, not worrying about my patients, not worrying about my new office, which with New York real estate is crazy. I actually spent the nightmare trying to figure out which EMR. I went through 3 till I adapted, and I had no help from the medical establishment. Frankly, I don't have a computer science degree from MIT, so it's a little challenging.
Kind of hard to follow that up. Whenever I think of electronic health records, especially kind of what's coming in the future, the 3 things that come to mind for me are mobility and workflow is the first thing, which is everyone's talking about the move towards mHealth and using phones and trying to put in patient information into your EHR. For me as a physician, it really comes down to what's the new workflow going to be? How am I going to see my patients more efficiently? How is that data going to inform me and then help me get a 15 or 20-minute appointment cranked out more efficiently instead of, great, they brought in their Nike Fuel Band. I don't know what the hell to do with this data. You can print it out for me, but then I'm not going to take the time to look through it. So working through how that workflow is going to change is going to be important. The second thing is going to be privacy. I do think that as you talk to younger and younger people, privacy is not as big a deal. But for many people that kind of came up in the age of HIPAA, where you're worried about saying anything to anybody because something could happen, that is something that's going to have to be figured out a little bit better than it is now, and educated to the rest of us, because I could ask anybody in a hospital, 5 different people, to give me 5 different answers of how we handle HIPAA and privacy. And then the third thing is really the value of the health data. I'm sure this has all come up with a lot of the startups that are around here. I think there are several companies like Patients Like Me that have actually, and Practice Fusion, that are actually taking that data and selling it to pharma companies, insurance companies, whatnot. Even credit companies like TransUnion are actually re-identifying the data and selling it to people so they can figure out who you are and what conditions you have. That value is going to actually indicate something to people that, wait, I generate this data on a regular basis and somebody else is making money on it. That doesn't seem right to me somehow. I don't know how that's going to be worked out, but ideally I would think from a patient advocate perspective that, again, I've got my little fuel band on here, so I'm trying to get my pedometer going. In the future, I'd like to be able to negotiate with my insurance company for people that are my age, my sex, my race, my height, my weight, and say, I do this much activity. I deserve a lower premium. I think that's the way things need to go. Whether that goes the way or not is another matter.
Okay, great. Just before we open up the panel to questions from the audience, I'm just going to say, if you can please nominate one person from the panel that you would like to answer your question. We're just going to take one answer per question so that we can get through as many questions as possible. All right, just one other quick announcement before we move on to that as well. If you like the content of tonight's program, I want to just give you a quick update on the Doctors 2.0 program in the second quarter. It's going to be called Health 2020, and it's going to be a TED-Med style format. We are currently opening up a request for speakers to come in and talk to us and share your ideas about what you see the future of healthcare in 2020. We're looking for a presentation which will be no more than 7 slides and 7 minutes, and potential topic areas include technology applications in healthcare delivery, remote patient monitoring, medical apps, integrated health records, medical and pharmaceutical innovations, how you would apply technology from other industries to improve healthcare. The deadline for submissions for proposals for talks is going to be the 24th of May, and presenters will be notified the first week of June if their submission has been accepted. So this is going to be a really great program. Save the date. It's going to be on June 26th, and there'll be more information about this in emails. And really quickly, Alex has a quick announcement about a raffle draw tonight.
Yeah, if anybody actually read my emails, Did anybody actually read my emails? You guys must have, because you registered. So, thank you guys. And so anyway, Doctors 2.0 is a conference in Paris. And it's a great conference, a lot of physicians. They have patient scholarships, which they're funding through MedStarter. So go to MedStarter and fund the patient scholarships. But what Denise Salver wanted to do is she wanted to give one free pass to the conference. So that white bowl that's being passed around is for your business cards. because I failed to actually make a little slip of paper for all of you, sorry. And it's really not just the trick to get all your business cards, really.
It should all be electronic by now.
Exactly, I have all your information anyway. Please put it in there and stay to the end, and we will, if you're still here, not raffle off, but we're gonna give away one free ticket. So if you wanna go to Paris, this does not include the airfare, and go to a really great conference for free, put your card there. That's it, thank you.
All right, great. Questions from the audience, please. Okay, over there, if you can tell me who the question is based for. Yep.
I don't know your name.
Dr. Matthew.
Dr. Matthew. Dr. Matthew, okay.
Sure.
My name is Natasha. I have a consumer-facing app called Simple. And actually, well, I'll ask you, but because your physician who seems to stand as far away, not as much in favor of patient engagement, I guess.
Oh no, I'm very much for patient engagement.
Okay, I might have misunderstood what you were saying.
Okay.
But I was just wondering about the comments on data privacy and how that's going, and how patients are going to receive data privacy with the removal of pre-existing conditions as articulated by Obamacare.
Let me restate it to make sure I've got the question right too.
I was going to ask you two questions. So forget about the whole first part,
Okay,
and then just go to the data privacy part.
So the data privacy part, just state it one more time to make sure I got it, because I think I got confused with the Obamacare part. Just, what about the data privacy part?
You were saying that you thought that patients were going to actually continue to feel a sense of privacy over their health data.
I think that...
I'm kind of wondering how that's going to change with the removal of pre-existing conditions.
I do think that over time, with everyone having to be covered by Obamacare, that will be less of an issue. But at the same time, there's nothing in Obamacare that prevents healthcare organizations from repricing the insurance policies based on your pre-existing conditions. They can actually reprice it to the point where it is very expensive for you. Same thing with self-insured organizations. They can reprice it so that even if it's something that they offer to their employees, it still can be more expensive than you can afford.
For the individual.
Even for the individual. And I think they're also making changes like you may or may not be able to insure your spouse, you can insure your kid till 26. There are all these little changes that are coming along the way that will really alter the landscape, but also force people towards exchanges, towards having to buy their own insurance policy. And that also may be a challenge because, again, unless you're going into the Medicaid roles, where they are trying to offer a low-cost alternative, a lot of the insurers, again, only have to offer something that makes sense for them cost-wise, that may not be necessarily affordable for you. So we'll have to see how that plays out.
We have a question over there. Who's your question for?
Actually, my question is 2-word responses from each of the panel members, if that's okay. So, as a 20-something medical student, seeing all this change coming down the pike, trying to think about a 30 or 40-year career, would your decisions around your specialty in medicine be the same, seeing the changes coming down the pike, yes or no? And if no, would it be different? And if no, which specialty would you choose?
Okay, that's that one. Mine would, I would have dropped out of the
Okay. Yes.
Follow the trends. The trends are technology and specialty business knowledge to really follow.
I actually not only didn't have any medical school debt, but my tuition was free. I went to school in Europe. And that did not influence my going into a super specialty in cardiology. So I would have done it the same. But I think that a key in the future to get primary care physicians is to do away with med school tuition. And that's going to get physicians doing what they need to be doing.
Yeah, I
You've been to a guidance counselor. The answer is going to be it depends. Depends on what you want. Money, work-life balance, and where you think your life you want to be in 10 years.
With all due respect, I was hoping for your opinion.
I love allergy. I think it's great. I'm happy what I chose. But when I chose it, I knew I could be my own boss for 30, 40 years. It's nothing like being your own boss, even though it can be slavery, but you don't get along with your boss.
Another question from the audience, anybody? No, we're all adjourned. Who's your question for?
Hi, Evan Shore. Question for you. What was the nature of the doctor-to-doctor application that you're building? Like, what are the use cases that you're building?
Most of it, is this working? I can speak louder. Yeah. Okay. Can you speak louder? Okay. So our app, which we have from a grant actually from LIJ, is basically doctor-to-doctor sign-out on patients. It's updated daily. It allows for residents to basically talk about their plan, what needs to be done for the night float, which I actually work as a night hospitalist, so I have to go through all of their sign-outs. And we, in a way, we kind of teach the residents on what the key things are to manage the patients are through the sign-out. We also coordinate with our physicians in practice, so they actually use it to manage their inpatient while they're out in their offices.
Any other questions?
Dr. Simon Sikorsky.
Hi, I'm from Empowered Doctor. I got a question for Dr. Lubitz. So we found a lot of doctors recommend medical apps to patients, but they fail to recommend the apps on their own websites. Why do you think that is?
Are you referring to academic doctors or people in
Both private, academic, hospital-based, private-based. Why don't they actually prescribe apps?
I think awareness, number one, and number two, I just think really the EMR has been, and the threat of Obamacare and what it's going to do has so overwhelmed them that I think they felt paralyzed by the coming on of technology. I think, you know, what you said is important. The difference between important information and volume of information. I think making your app obviously valuable to doctors. One side comment, I just took my boards. These were the top doctors in America. They taught the course. It's people, we all know each other 30 years. We've been taking the board. Do you know that course was taught the same way I was taught in medical school in 1980? I mean, you know, the least intelligent person is an overeducated person whose knowledge-based, not knowledge-based, whose emotional EQ of learning froze 20 years ago when they attained their PhD. It's a real problem. I find, frankly, that high school grads are easy to adapt to new information in medicine and very educated patients.
So I just have one comment. I want to know when you're going to develop the app that teaches doctors how to incorporate humor in their physician-patient interaction.
I actually have done some stand-up within a comedy club where I diagnosed them with deficiency. And you know what? It's much harder. It's much harder than one-on-one on a patient, and it pays a lot less. I mean, I went to Lee Allen's high school. That's where the deal comes from. I mean, you grow up in Brooklyn. But on a serious level, I really think what you're doing is great. I think apps are great. But I do think the technology has to be humanized to communicate quickly what needs to be done. All great, as I say to my wife, who took, 9 months to redo her bathroom. I only used to take 5 minutes in a New York City hospital save a human life. I can't see where designing a bathroom should be 400,000 times harder than saving a human life. So I think the key to medical apps is getting the key information to the patient.
All right, my name is Chris. Anybody can answer this, whoever wants to answer. But so I've heard the discussion about it can be difficult for communication to transcend between provider to the next provider and kind of the siloed effect that happens. So what do you think about the patient truly owning their own record? So in other words, you have a visit, you document the visit in whatever software, you print out the visit and you give it to them and they actually own it. Because I know I've gone to the extent of just trying to ask at the end of every visit for a printout
Yes, so
and loading it up myself.
That is actually the law now, that you have to have within 24 hours a total printout or electronic record of your encounter. If you want your entire electronic chart, they are mandated to give it to you within 30 days. I'm sorry? Well, people need.
Sorry.
Well, people need to know what the law is, and that's, you know, should physicians be mandated to disclose that to you? Probably, but, you know, would they do it? You know, it's sort of, you know, I don't know, is the answer, but absolutely.
But how do you personally feel about that? Like, do you think that they should?
Absolutely. First of all, there's no ownership of data. What the patient owns is the right to give data to whoever he or she wants. There is no more ownership of that. The whole concept of ownership comes from a paper chart. So the data is people's to share, but it's for the patient to determine who it's shared with.
The problem with that, David, is that the patient himself or herself cannot get the data. This is the e-patient Dave, give me my damn data thing.
He's talking about an encounter. I mean, certain data from devices, I agree with, but when you're talking about an encounter or a lab result, that's the law. They have to have.
Look, I'm just going to jump in if you want. Look, I'm all for actually patients having their data. The question I would kind of turn back is, how do you interpret it? What do you do with it? Now, if you have a hack where you know how to interpret that data and you can do something with it, that's great. I'd like to be able to check in on you once in a while, make sure you're doing it right. But if you know what you're doing, you know what the data means, and you know how to manage your condition, that's great. The question is, you, especially everyone in this audience, is part of a broad range of patients we see.
Well, if I can answer that just briefly, I guess like I tend to use it not so I can go and do my own research, but so I can give it to the other physician who I'm talking to that has a related issue. You can like pull it up and like, huh?
That's all point of an EMR.
But
I'm part of an NYU Health Exchange. I have a permission now, I'm part of the NYU. There were some physicians here from NYU. I have a general permission to, when they sign this permission, every doctor in the NYU sphere has the right to have my data. I have a portal that's part of the new Obamacare law. That portal gives you the right to your data right there. The only question becomes, if you have abnormal data, do I have the right to have you talk to me first before accessing it? That's my thing. I don't want to lose. The other thing is that this may inhibit people writing their honest impressions down on something.
Well, I thought like maybe legal ramifications.
The legal aspect of getting your test results is actually varies from state to state. And what is coming out now around the country is that patients should be able to get their test results directly, but there needs to be a certain limited time period between which the physician gets it and the patient, such that there's time for the physician to digest and then recommend stuff. On another note, as far as implantable devices goes, I am working with a patient portal now that will not only give the patients their device, but I have devised, and it's actually in an article in the Wall Street Journal that was published about 8 months ago, little explanations of what that data means, such that it's algorithmically determined and associated with the data. And so I understand that point as well.
Okay, we're going to take one last question over here, and then we're going to have to call it a day. Yeah, who's your question for?
Yes, it's for Dr. Scher. My name is Gerald Shine. And you were touching on the House debate about the medical apps. And I was reading that some people consider medical apps a medical instrument. Some consider it an accessory to a medical instrument. So I'd like you to elucidate on that and what the role of the FDA is going to play in the development of these apps. Any
phone or app, or any app that makes the phone a medical device as defined by the FDA, which is the standard definition, or is an accessory to making that phone a medical device, will fall under the auspices of the FDA. It's estimated that only about 15% of apps are going to fall into that category. The other question about this medical device tax is that the government has already said that they are not going to treat medical apps as medical devices in the true sense of the word with regard to this tax.
All right, great.
Thank you.
I think it's been a really fantastic discussion. Thank you so much to all the audience for participating and the great questions. Thank you to a superb panel. Thank you to Anthony Manson, who had to leave. I hope everyone's enjoyed the program, and I thank everyone for staying till the end. I believe that there's an after-gathering at the Vault at FAF, which is on Broadway between Bond and Bleecker.
Yes, it's between Bond and Bleecker, and it's right on Broadway. It's called the Vault, not that Vault. The Vault at PAF. But anyway, it's right up the street. So I just big round of applause for our panel and for Aafia Chaudry. I want to thank you all for coming tonight. It's been a really great show, and it's all Aafia's credit. Also to the credit of Megan and Donna and Sunny. We're going to do this raffle. Does anybody want to stay for half an hour and drink and eat and enjoy? Because I could do this raffle right now, right? Did everybody put their card in already that wants to? Okay, so this is for the Doctors 2.0 conference. Okay, there's going to be no chicanery, right? So let's say somebody in the audience who has started a company. Anybody started a company? Show of hands, show of hands, okay. Anybody sold it for over $200 million? Anyone? 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 Oh, Peter, there you are. Okay, so we know that he cannot be bribed. This is Peter Frijal. He is one of the leaders. He created what? MedPage Today? Okay, and he talks to his phone, and it talks back to him.
Don't let the facts get in the way of a good story, Alex. It was actually, I actually didn't start MedPage, I started Medscape, but I work with MedPage. Okay, so this is a trip to France, and a free ticket to a conference in France, so someone's going to get to spend midnight in Paris, where, like in the Woody Allen film, they can experience La Belle Époque, or American healthcare, HIT. That was a joke. All right. All right. The winner is, drum roll, music, Sambit Mishra, founder and CEO of Q-Medic. I'll collect my fee at the end of the... Thank you, Alex.
Okay, congratulations. Okay, so see y'all at the bar. We have about half an hour here. Please clean up after yourselves, because if you don't do it, then I have to. Okay, so any garbage you see, please pick it up, put it someplace. If a couple of people want to stay after and help put this place back in order, everybody, if you can take a chair or two and start stacking them together, it would be appreciated. Thank you all for coming, and good night.